Hello.
Prayak, can we start?
So it's 3, 2, 1. Over to you, ma'am.
A very good evening and warm welcome. My name is Dr. Charmi Prajapati, and I'm part of medical affairs team at McLeod's Pharmaceutical. As we all know, diabetes and heart failure are closely linked together. Patients with type 2 DM have 2 to 4 times more likely to develop heart failure. And likewise, heart failure is itself a risk factor for diabetes. So today, the topic for today's session is bridging the gap in heart failure management with or without diabetes, dapagliflozin takeaway. And to go further into the topic, we have with us our esteemed speaker for the day, Dr. Ullas R Mullamala. Sir is interventional cardiologist and is currently HOD of cardiology and cath lab in charge at Holy Family Hospital, Kerala. Sir has published various research papers in international journals and has been part of clinical trials as investigator. It's a pleasure to have you, sir. And now I hand over the session to you.
Okay, thank you so much for the nice introduction. Am I audible?
Yes, sir, you are audible.
Okay, thank you. So, good evening to everyone. Today's topic is bridging the gap in heart failure management with or without diabetes, dapagliflozin takeaways. As mentioned during the introduction, people who have type 2 diabetes
Hello, sir.
are 2 to 4 times more.
Actually, the slides are not visible, sir.
Okay, then let me.
You need to share it
once
first.
Again.
Yeah.
Okay. Is it visible now?
Not yet, sir. Actually, I shared the introductory slides, so you need to re-share the slides again.
I think now it's working.
Yes, sir, it is visible. Your screen is visible.
Visible now?
Yeah.
The slide is moving?
Yeah. It's perfectly fine.
Okay. People who have type 2 diabetes are 2 to 4 times more likely to develop heart failure than someone without diabetes. So it is a 6-year CHF incidence per 1,000 person years by age group. You know that you can see that is diabetic patients are more at risk of developing heart failure. You see the pathophysiology of diabetes and heart failure. Diabetes can cause heart failure by ischemic cardiomyopathy or by diabetic cardiomyopathy. If you see the red arm, you can see that diabetes leads to inflammation, dyslipidemia, endothelial dysfunction resulting in CAD and ischemic cardiomyopathy. And on the green arm, you can see that diabetes leads to cardiomyocyte hypertrophy, left ventricular hypertrophy by RAS activation, fibrosis, calcium handling, fatty acid utilization, the autonomic dysfunction. All these factors lead to diabetic cardiomyopathy, and ultimately it results in heart failure in diabetic patients, either due to ischemia or as a part of the diabetes itself. So diabetic and diastolic dysfunction. The initial diastolic dysfunction that characterizes the early stages of diabetic cardiomyopathy can be viewed as just the tip of the iceberg if left untreated in people with the type 2 DM. The stages of diabetic cardiomyopathy progress from the initial onset of hyperglycemia and diastolic dysfunction through the later stages of hypertrophy, angiopathy, ischemia, and heart failure with the systolic and diastolic dysfunction. The 4 pillars of heart failure management in this era are: one is ARNI, that is angiotensin receptor neprilysin inhibitor, beta blocker, a mineralocorticoid receptor antagonist, SGLT2 inhibitors. So these are the 4 pillars of heart failure. So when to start all these agents? While the guideline-directed medical therapy is proven to reduce morbidity and mortality, many eligible patients with heart failure with a reduced ejection fraction are not receiving one or more of the recommended medications often due to suboptimal initiation and titration in the outpatient setting. Hospitalization serves as a key point to initiate and titrate GDMT. For evidence-based therapies have clinical benefit within 30 days of initiation and form a crucial foundation for heart failure with a reduced ejection fraction therapy. So optimizing GDMT for heart failure. The DAPA-HF and EMPEROR reduced trials showed the significant benefit of SGLT2 inhibitor in the treatment of patients with heart failure with reduced ejection fraction, including reduction in all-cause mortality by 13% and recurrent CV hospitalization by 25%. These clinical benefits can be seen within 12 days of initiation. So let us see what are the guideline recommendations. If you go through the 2021 ESC guidelines for the diagnosis and treatment of acute and chronic heart failure, as previously mentioned, the 4 pillars, an IC inhibitor or ARNI, beta blocker, MRA, and SGLT2 inhibitor or loop diuretic forms the class 1 recommendations. If the EF is less than 35% and QRS is less than 130, consider ICD. It's a class 1 indication if it is ischemic and class 2 indication if non-ischemic. If the EF is more than 35% or device therapy not indicated or inappropriate, and if symptoms persist, consider therapies with the class 2 agents. If sinus rhythm and an LVF less than 35% and a QRS more than 130, consider CRTP or D. So let us have a close look. The recommendations for the treatment of heart failure with a reduced ejection fraction. Dapagliflozin or empagliflozin are recommended for patients with the heart failure to reduce the risk of heart failure, hospitalization, and death. It's a class 1 indication with a level of evidence A. Recommendations for the prevention of chronic heart failure. SGLT2 inhibitors are recommended in patients with the diabetes at a high risk of CV disease or with the CV disease in order to prevent heart failure hospitalization. It's also again a class 1 recommendation with a level of evidence A. Recommendations for treatment of patients with heart failure and diabetes. SGLT2 inhibitors are recommended in patients with the T2DM at a risk of CV events to reduce hospitalization for heart failure, major cardiovascular events, end-stage renal dysfunction, and cardiovascular deaths. And these are also recommended in patients with the T2 diabetes and heart failure with reduced ejection fraction to reduce hospitalization for heart failure and cardiovascular deaths. In the 2021 update by ACC also, SGLT2 inhibitors are recommended as a class 1 agent. So, Egyptian Atherosclerosis and Vascular Biology Association consists on the use of SGLT2 inhibitors in heart failure with reduced ejection fraction. So this can be used effectively and safely as a treatment of heart failure in addition to the standard of care in those with or without diabetes. They can be used at any point of the timeline of heart failure with reduced ejection fraction, regardless of the treatments, and the earlier the better. Thus, these can be used as first-line therapy. At present, it is reasonable to favor dapagliflozin based on DAPA-HF or empagliflozin based on EMPEROR reduced. Both have shown benefits when given in the 10 milligram dose at any time point in the timeline of heart failure in cases with heart failure with reduced ejection fraction. We recommend using SGLT2 inhibitors in those with the heart failure with reduced ejection fraction less than 40% with the NYHA class 2 to 4, with or without diabetes mellitus, and if possible, with a maximization of RAS. We recommend the inclusion of diabetologists and nephrologists whenever required for the follow-up of heart failure with reduced ejection fraction, especially if the patient is suffering from DM and has CKD. So, dapagliflozin, as per the NICE guidelines, dapagliflozin leads a significant reduction in worsening of heart failure events, cardiovascular, and all-cause deaths. So, initiate treatment using discussion of the risk and benefits with patients. SGLT2 inhibitor, bridging the missing link in heart failure with or without diabetes mellitus. So, the first OID class to reduce cardiovascular mortality and heart failure risk. The only class with the cardiorenal benefits with or without diabetes. The OID class recommended by latest guidelines. So we know the mechanism of SGLT2 inhibitors. And its effect results in a reduction in the plasma glucose, reduction in body weight, reduction in blood pressure, reduction in plasma uric acid, reduction in glomerular hyperfiltration. So it offers both cardiac and renal protection. The cardiac protection in the form of glucose reduction in the cardiac afterload and preload, increases myocardial oxygen supply, increases cardiac systolic and diastolic functions, decreases major adverse cardiovascular events and risk of heart failure, and nephroprotection in the form of reduction in intraglomerular pressure, reduction in blood pressure, and reduction in the progression to CKD. So if you see the therapies for heart failure and we take SGLT2 inhibitors, all patients with reduced ejection fraction with or without diabetes, normal to high BP, mild to moderate CKD, or T2 diabetes mellitus, all favors an SGLT2 inhibitor, and safety concerns or contraindications are very low eGFR and volume depleted or acute serious illness. But all SGLT2 inhibitors are not the same. Let us see. It's a comparison of CV indications for SGLT2 inhibitors for patients with type 2 diabetes. We can see the time frame of various landmark trials. So dapagliflozin has been shown to prove benefit both in primary prevention aspect as well as secondary prevention aspects with regard to heart failure for hospitalization for heart failure. So if we compare the oral anti-diabetic agents, if you see dapagliflozin at the bottom, it causes a reduction in hospitalization for heart failure, both in primary prevention as well as secondary prevention aspect, and progression to diabetic kidney disease or progression to chronic kidney disease, both it's a primary and secondary prevention aspect. Let us see certain risks associated with the use of SGLT2 inhibitors. It's the genitourinary infections, particularly mycotic infections in women and uncircumcised men, may lead to increased urinary frequency but are not directly associated with UTIs. Hypertension, diabetic ketoacidosis, called a euglycemic ketoacidosis, limb amputation, hypoglycemia in patients with comorbid T2DM, and fractures, but it is very low risk. So genitourinary infections are the most common that we usually see with SGLT2 inhibitors. Dapagliflozin, evidence from landmark trials. If you see the various landmark trials for heart failure with regard to dapagliflozin, is the DAPA-HF, which came in 2019. The Declare TIMI 58, which came in 2019. The dapagliflozin expanding indications in heart failure with the preserved ejection fraction. The DELIVER study, that is dapagliflozin in heart failure with the reduced ejection fraction, which came recently. The DELIVER is the largest and the broadest clinical trial of this population to date and enrolled high-risk, well-treated patients with the heart failure with a mildly reduced and preserved ejection fraction. The high-level results from the DELIVER phase 3 trial showed that dapagliflozin reached a statistically significant and clinically meaningful reduction in the primary composite endpoint of cardiovascular death or worsening heart failure. The trial was conducted in patients with heart failure with a mildly reduced or preserved ejection fraction, defined as an EF greater than 40%. The safety and tolerability profile of dapagliflozin in the DELIVER phase 3 trial were consistent with the well-established safety profile of the medicine. Dr. Scott Coleman, professor of medicine at Harvard Medical School and Brigham and Women's Hospital and principal investigator of the DELIVER phase 3 trial. And his words, let us see his words. DELIVER is the largest and broadest trial to the date, and in heart failure with a mildly reduced or preserved ejection fraction. The results of DELIVER extend the benefit of dapagliflozin to the full spectrum of patients with the heart failure. So, if you see the chronology of the key trials evaluating dapagliflozin, previously we have Declare TIMI, post-hoc trial of Declare TIMI, Define-HF, and recently we have DAPA-HF, DAPA-CKD, and an array of ongoing trials. Dapagliflozin recommendations for use in heart failure with or without DM. ACC clinical pathway in heart failure guidelines. Dapagliflozin 10 mg daily for reducing the risk of heart failure hospitalization adults with the DM and established cardiovascular disease or having multiple risk factors, and for reducing the risk of hospitalization and cardiovascular death in heart failure patients with a reduced ejection fraction. In European Society of Cardiology, dapagliflozin is recommended for prevention of hospitalization for heart failure in patients with the DM and established CV disease or at high risk of CV disease. The use of dapagliflozin is also recommended for reducing the combined risk of hospitalization for heart failure and cardiovascular death in symptomatic heart failure with reduced ejection fraction patients already receiving guideline-directed medical therapy, regardless of the presence of diabetes mellitus. So the protocol for the use of dapagliflozin for the treatment of heart failure with reduced ejection fraction. Does the patient have diabetes? No diabetes. Still, you can start an SGLT2 inhibitor. If it is type 1 diabetes or other type, if the patient has type 1 diabetes or another type of diabetes or decay history, seek input from hospital or community diabetes team. And type 2 diabetes, patients with the type 2 diabetes, are they on insulin or a glucose lowering medication? If no, not on insulin, start SGLT2 inhibitor in addition to current diabetes drugs. Usual diabetes team to review diabetes medications, use supportive checklist. On insulin or a glucose lowering medication, ask patients usual diabetes team to start SGLT2 inhibitor. So dapagliflozin does what really want any drug to do. It improves symptoms, it improves survival, it reduces hospital admission. More than 80 trials ongoing beyond glycemic control. So dapagliflozin, bridging the gap, recommended by reputed bodies and preferred guidelines, ADA or ACC, or in the management of type 2 DM with the ASVD, heart failure, or CKD for reducing hypoglycemia and weight gain. The first and only FDA approved SGLT2 inhibitor for patients with heart failure with reduced ejection fraction, with and without type 2 DM. No other SGLT2 indicator to reduce cardiovascular death in patients with heart failure with reduced ejection fraction, with and without type 2 DM. So promising results in heart failure with the preserved ejection fraction also. More than 350 completed trials and 80 ongoing trials have proved the role of dapagliflozin in glycemic control and beyond. Landmark CVOT trials like DAPA-HF have shown survival benefit in heart failure with or without type 2 DM. And the future is bright, a much needed molecule bridging the gap of heart failure with or without diabetes. Thank you. Okay.
So we'll look for questions.
Okay, fine.
So, what is your final take on dapagliflozin based on your clinical practice on its efficacy and safety?
So, certain points I wish to mention is that dapagliflozin is an agent that can be used in the whole spectrum of heart failure, whether it is reduced ejection fraction, whether it is mildly reduced ejection fraction, or it is preserved ejection fraction. And obviously, in patients with the heart failure with a reduced ejection fraction, it is immaterial that the patient is having diabetes or not. Obviously, SGLT2 inhibitor or dapagliflozin forms the main 4 pillars of treatment, along with an ACE inhibitor, ARB, or an ARNI, or a beta blocker, or an MRI. So, in our practice, we usually start all these drugs while the patient is admitted in the hospital prior to discharge, either one by one or later. So, dapagliflozin will obviously a part of the regimen, irrespective of the diabetic status of the patients. But once you are starting dapagliflozin, in between a patient with a diuretic control, make sure that the patient is euvolemic, especially if the patient is hypovolemic or on high doses of diuretics. Once you start dapagliflozin, we have encountered certain problems. So make sure that the patient is euvolemic. And on certain times, if the patient is on an ARNI and an MRI and on diuretic control, when you start dapagliflozin, your serum creatinine may rise a bit, that we usually see in clinical practice. But after a period of around 2 to 3 weeks, once you optimize other drugs, it comes down. So these are the 2 important things which I want to mention.
Thank you so much, sir, for sharing your clinical insights. I think in absence of further questions, we can end the session. So lastly, sir, we would like to thank you for taking the detailed session and sharing your insights. We also thank our audience for joining in and our technology partner for smooth streaming of the session. Thank you, sir. Very good.
Thank you. Thank you.
Thank you, ma'am. So with your permission, shall we conclude this meeting?
Yes.
Okay, thank you, ma'am. So from here, now I'm ending this meeting.